Good evening, everyone. Again, welcome to our Woo You webinar in partnership with IKA. You don't see what you don't look for, the impact of missing early onset of keratoconus with Dr. Christine Sint, Dr. Megan Allen, and Dr. Anna Ostrovsky. I am your host, Elise Kramer, and it is such a pleasure to have everyone here. Thank you so much for being with us, to all our wonderful speakers. So these are moderators for the evening: Dr. Barry Iden, CEO and co-founder, IKA, North Suburban Vision Consultants in Deerfield, Illinois; Dr. Andrew Morgenstern, president and co-founder of IKA, Walter Reed National Military Medical Center, Bethesda, Maryland. Thank you so much for being with us.
Our next speaker is Dr. Megan Allen, who's an assistant professor at Illinois College of Optometry and the director of pediatrics and vision therapy at North Suburban Vision Consultants. Dr. Allen is our expert in the pediatric realm tonight as we go ahead and talk about keratoconus and how it affects the pediatric community. Next slide. Nothing to disclose financially. And I'm thrilled to have, again, one of our speakers at our meeting at IKA in May 18th and 19th, Dr. Anna Ostrovsky. She's a professor of ophthalmology at Eastern Carolina University and chief of ophthalmology services at Eastern Carolina University. She's formerly from New York City. She's a cornea and external disease fellowship trained ophthalmologist. And I know she has a significant amount of experience with keratoconus, individuals with keratoconus. And most specifically, I've been learning so much from her about how Down syndrome affects keratoconus and the comorbidity of keratoconus and Down syndrome together. I know she's got a tremendous amount of information to present to us tonight. We're going to go to the next slide and get this presentation started. No financial disclosures, and all financial relationships have been mitigated.
Okay, so I'm going to shift gears a little bit and talk about, when would you consider referring for tomography or referring to your cornea colleagues. So you have separated this by vision, although that doesn't always correlate, but sometimes your patient will come in and they're still 20/20. They're very, very early, but you see certain things that would make you suspicious. One, they're complaining of some frequent changing refractions. Now you're still getting them to 20/20, but when that posterior cornea, that posterior elevation starts to come up there, that can actually cause refractive changes. You may have a child or an adult who has high risk behavior of eye rubbing or some associated conditions like atopy or vernal keratoconjunctivitis or severe allergies, and you should be on high alert for those patients. Your syndromic patients or folks with intellectual disability are also at higher risk. At this point, your topographic and your keratometric Ks will look normal if you can get those. But if you have access to a tomographer, you may see some early posterior elevations.
And I think Chris still has control of the screen. Chris, could you advance the slide?
No.
She's fighting me. She has control. We'll give it again.
Okay, let's try again.
No, you have it.
Okay, it's not advancing.
Could you try the arrows on your keypad in your keyboard? Yeah.
That's what I'm using.
Gotcha.
Oh, there we go. Okay, let me go back to that. Perfect. So now you've got your patient who comes in and they have a vision that's slightly worse than 20/20 perhaps, and you're looking at some potentially mild disease. What would tip you off to this? So again, your frequent changing refractions, either something you're measuring on your exam or the patient is reporting this. You may have some early decline in the best corrected vision because now you actually have some changes in that anterior cornea. You may start to see some increase in myopia or astigmatism. And even though I didn't put it on the slide, this is where you may start to see some changes in the keratometry, although they may be mild, as well as the topography. You may start to see some early clinical signs here. So if you see that abnormal retinoscopic reflex or an early fly shoring, this could be your tip-off that you can refer this patient just to make sure that they don't have something going on in their tomography. At this point, you'll also start to see that anterior and posterior elevations on any Scheimpflug imaging. With advanced disease, it's easy, and hopefully you're picking these up. You will have some significant decline in best-corrected vision, this increase in myopia and astigmatism, and you'll start to see some of those late clinical signs like Vogt stria, a visible cone, some apical corneal thinning or scarring, and you may see that Munson sign. And at that point, that topography is going to have lots and lots of color, and you know that there's a large cone. So the challenges in diagnosing keratoconus in pediatric patients, sometimes, when they're really little, they won't complain of vision loss, and it's quite difficult to examine them, both in the chair and also at the topography or tomography machine. But it can be done, and Dr. Allen will talk about that in the next portion. When I talk about treatments for progressive keratoconus with my patients, right, and I know that usually the referrals that I get, the patient already has progressive disease. And so we talk very separately about disease stabilization as a separate entity and then visual rehabilitation as a completely separate entity. When I tell my patients that I'm going to do corneal collagen cross-linking to stabilize their disease, I generally don't promise them visual improvement. The corneas do tend to flatten a little bit, about 1.2 to 1.4 diopters, but it's unpredictable and most frequently does not result in a visual improvement. So we then talk about, after the cross-linking, how are we going to get this patient to see better? And then we talk about, glasses and contact lenses as some non-surgical options versus surgical options that would be undertaken sort of as a last resort when the non-surgical options don't work. And we'll talk about some of these later. So the rationale for cross-linking, really the treatment depends on the severity of the disease and the disease stability. Some older patients who come in their 40s or 50s may already have auto cross-linking that has happened during their lifetime, and their cornea, although abnormal, has stabilized and is not progressively getting worse. Those patients may not need to be cross-linked. But for the progressive patients, the greater the delay in diagnosis, the higher the risk of requiring a corneal transplant. And without treatment, 20% of these patients will require PK for visual rehabilitation. Detection and prompt treatment with corneal cross-linking, once progression is observed, can stop the keratoconus and preserve good visual acuity with glasses and or contact lenses. In kids, the disease also can progress very quickly, as Dr. Sen said, and PKs have a significantly higher failure rate in children than they do in adults. So they really are a last resort option for us. We'd like to avoid them. This is a study from the eye bank and corneal transplantation data that shows you a decrease in corneal transplantation that has happened in the years and has come down from 2005 all the way to now. And a lot of this was due to the increased usage of endothelial keratoplasty, but also in the United States, with the advent of approved cross-linking around 2016, the use of PKs has also continued to decline. This is a study that shows a worldwide distribution of surgical indications for corneal transplant, and you can see that progressive decline, the progressive decline in use of PKs for ectasians and thinnings. And that's the little arrow that shows for us where in the United States, corneal cross-linking became approved. In the US and outside of the US and in the Middle East and other places, corneal cross-linking was first described in 2003 and became pretty standard of care around 2006 to 2008. So it's been around a long time. There's a couple of studies of indications in corneal transplant in children, and you could see the large blue circle that takes up more than half is still, the indication is still keratoconus. So in this study, it was 61%, and in this study by Zhu and Prescott, over, I think it's a 79% in children, the indication was ectasia and PKP. So it's still very, very significant. Now, the pediatric corneal transplants are very challenging. They definitely have a higher risk of rejection. And they are associated with a lot of complications, such as corneal scarring, neovascularization, glaucoma, cataracts, wound dehiscence, all kinds of things, infection. Kids are also notoriously difficult to handle after a corneal transplant. It's hard to keep them from touching their face and continuing to rub, and it can lead to really devastating consequences after a transplant surgery. So let's shift a little bit back to cross-linking and talk about, what are the indications for cross-linking when you're talking to your patients? So definitely progressive keratoconus or ectasia. We make sure that their corneal thicknesses are above 400 micrometers. If they're significantly below that, we cannot safely perform cross-linking in the United States. If we need to make sure there's no significant corneal scarring. With mild scarring, we may still be able to cross-link them, but with significant scarring, especially after high drops, it's not indicated. We definitely don't want anyone who has a scar from prior HSV keratitis, because that can get reactivated by the UV light. And I always discuss with my patients the realistic ability to rehabilitate their vision with contact lenses or glasses after cross-linking. If they are so allergic that they cannot wear contact lenses, then I wouldn't be able to. It may not be worthwhile to cross-link them, because it will not yield eventually to a usable visual effect, and those patients may actually be better candidates for a surgery. The cross-linking procedure is approved by the FDA for children 14 and above, but off-label, it can be done for younger. And I have done cases of 4-year-olds all the way through, 14. So very, very briefly, this is what the corneal cross-linking machine looks like. We used riboflavin, which is vitamin B. We removed the surface layer of the cornea. And I'll go through some of these steps with pictures for you, but essentially the purpose of it is the interaction of the vitamin B with UV light in the stromal corneal layers creates stronger bonds and strengthen the mechanical integrity of the cornea and make a stronger tissue. So what can you tell your patients about the procedure if you're sending them to have one? We prepare the patient by laying them down supine in a recliner or stretcher. And this is if we do this in the office. We put a topical anesthetic in the eye, which can burn, and we place an eyelid speculum typically in the eye to keep the eyelids open. Now, for our pediatric patients, there are some really special considerations. For those kids that are too young to be able to cooperate in the office, sometimes I have to take them to the operating room and do the procedure under general anesthesia. And even then, sometimes admit them for several days afterwards to sedate them and prevent them from rubbing their eyes if they're having severe pain. I also may need to do a procedure off-label for some of these children, and we'll talk about that in a minute. If the procedure is done in the office and the child is able to cooperate, I do things slightly differently. We may practice with the child and the family, instilling eye drops. We go into the room several times. I have them take protective glasses home to practice those so they know not to touch their eyes after the procedure. I always allow the parent or the caretaker to stay in the room with them. The rooms are all pleasant, pediatric rooms decorated with pictures. We put music on and sometimes even let them watch a video if we can put it up on a selfie stick so they can watch the video with their other eye. And sometimes I don't use an eye speculum. So very briefly, the procedures, if I do this the standard FDA approved way, I remove the epithelium, then I instill riboflavin drops for 30 minutes. We recheck the corneal thickness and make sure that we're in the safe zone above 400. And then we provide 30 minutes of irradiation with UV light through the KXL machine. Afterwards, everything is washed off and we place a contact lens. Dr. Hafezi has a protocol that he uses in his association called Light for Sight, and I do something modified. Essentially, we look at the patient's pediatric and folks who are syndromic or have behavioral issues, looking at what is their compliance. Do they have normal compliance, in which case I will always try to do an epi-off procedure in the office. Do they have reduced compliance but are able to comply? I will then still try to do them under local anesthesia, but sometimes I will not remove the epithelium. And if they are absolutely unable to comply, like small children, then I will take them to the operating room, and sometimes we'll still do an epi-on modified procedure off-label. To try to figure out what level of cooperation the patients have, I use certain questionnaires, and it assists me to figure out how much the patient is able to cooperate. This is more useful in folks who are syndromic rather than children. With children, sometimes it's quite obvious. So what can patients expect after their procedure? What can you counsel them on? If they're getting a standard epi-off treatment, there's significant pain for 36 to 38 hours while the cornea heals. They will have very hazy vision for about 1 week, and it may take up to about a month for the vision to really come back to normal. The patient will need antibiotic and steroid drops for about a month. I don't know. My screen has gone through. Let's see if I can reverse back here. There we go. And I have the patient avoid UV light for about 3 months after the procedure because they can continue to have the cross-linking effects. And contact lenses can be refitted in about 4 to 6 weeks after the cross-linking. For visual rehabilitation, we'll try glasses, contact lenses, scleral lenses work amazingly well for this patient population. And then for those folks who either are not candidates for cross-linking or folks who are beyond the cross-linking threshold, there are several different types of surgeries that can be undertaken to try to visually rehabilitate these patients. A full thickness graft or a corneal penetrating keratoplasty is one. Intracorneal ring segments, there are several available. Intacs is the one most commonly used in the United States. These are PMMA segments that are placed into channels in the cornea and help flatten the cone. Very frequently, these can be done together with corneal cross-linking, and they can therefore achieve both a stabilization effect and a visual improvement effect. There are also CARES or corneal allogenic intrastromal ring segments that are currently being looked at, and these are basically donor irradiated stromal tissue from a donor graft that are also placed in channels and try to reshape the corneal surface. Deep anterior lamellar keratoplasty has better outcomes in terms of rejection because we are removing a partial piece of the patient's cornea and leaving the decimase membrane intact and the endothelium intact. It is much more difficult, technically difficult surgery, but has very promising results. And obviously, this is what we're trying to avoid. This is our patient who has keratoconus with high drops. And we cannot do a DALK on someone who has high drops because for this surgery, their endothelium has to be unaffected. And with high drops, we have a defect in our decimase membrane and endothelial. That's a side photo of it. And then there's also corneal tissue addition keratoplasty that was recently described by Peter Hirsch's group. And basically a piece of tissue is inserted into the cornea, again, also sometimes done with cross-linking to try to reshape and flatten that corneal surface. Okay, I am going to pass on the baton to Dr. Allen.
I can now take over the baton here a little bit here. I'm not getting that command to have me hold on to it. Did you send that over, Anne?
You should have it.
Should have it. I got it now. Okay, click to start. Try it one more time because it disappeared on me.
Nope, you have it.
I do. Okay, perfect. All right, wonderful. Let me go back because it looks like I progressed my slides a little bit quicker than I needed to here. Wonderful, perfect. So thank you guys. This is so wonderful to be a part. I'm so honored to be a part of this group with you all as specialists. I'm trying to now bring this all full circle. So A little bit of my background. I am a pediatric specialist, primarily focused in amblyopia, strabismus, research in that. I've worked in teaching. I worked at the Illinois College of Optometry for the last 15 years in the pediatric department, and had the honor of also working in private practice in both an ophthalmology-based practice for 10 years. And now for the last, I guess, over 3 years, 3.5 years, I've worked with Dr. Iden's practice, which obviously is very heavily focused cornea, difficult contact lens treatment and management. And then there's also the side component of this large pediatric base there. So what I kind of want to just talk about now is bringing this full circle and talking about really like the when, the how, and the who, right? So when we're starting to think about when are these red flags coming up in just a general pediatric case, whether it's a patient that's been referred to us specifically, or it's a general school kindergarten exam where we start to see these signs. And if we do consider doing advanced testing, right, doing our tomography testing, how can we do that? How young of an age? What are our challenges with our patients developmentally? How young can they be? And if we're going to do it when in the exam, is it appropriate to do it? Some tips and tricks on how to get them into the device. And then we'll kind of round out tonight's evening with talking about billing for this, right? And if this is, if we could do it on everybody, as we've learned from the research and Dr. Iden and Dr. Black's recent research telling us about, the prevalence and how much we are seeing this more, we would love to do it as a screening technique on every child that comes through, but just the limitations of that and the challenges that we are going through with that right now and how we can get by. Let me go down back here. Perfect. Okay, so let's talk about the when. So first scenario of when would be just on a general school age population, my general patient base that's coming in that I'm seeing on a regular basis, and I'm, doing my full comprehensive exams. Dr. Iden will know that my exams tend to take a little bit longer because I tend to love to cycloplege my patients, right? So critically important to really get that objective data. I'm not really relying as much on any subjective information from kids. I really want to objectively look with my skioscopy bars there, looking directly at the reflex to know kind of what the patient's prescription is and have an idea of how to treat from that. So if I have a history, like we've mentioned, if I have a history and we've seen this patient before, I know I've done run on them prior, but now I'm noticing changes, especially in cylinder or even increase in myopia dramatically, that I'm noticing that's quite different than in the past, my red flag might go up a little bit. Like, really, why is that happening? So I might consider potentially running some scans. All my patient that potentially might have a poor refraction endpoints, really challenging to get them to 20/20. And why is that? Maybe I trust them, I can do a mini manifest on them, but they're only able to stop at 20/25, not getting that clear 20/20 at their young age, and there's really no other risk factor. Again, that red flag might go up there. We've talked a lot about ocular history, and especially preventing the ocular itching and the rubbing that we saw so clearly in that video. That was just classic of a young child really going at it at their eyes. But really bringing that up with the parent as well to see if it's been happening. And then once we know that, treating it, right? Making sure that they're aware of the over-the-counter medications and saying, hey, if this is a general patient that's coming for a general comprehensive exam, if this isn't getting better, come back. I want to make sure your child isn't rubbing, right? If the over-the-counters aren't working, we have more advanced treatment now. We have other medications we can give. We can do, allergy testing and allergy shots. We want to make sure we're preventing that rubbing because we want to keep that cornea integrity really together. We do not want to damage that at all. Family history. So we've mentioned that there is a close relationship with, first degree relatives, and that it really becomes another red flag that's popping up. But bringing that up, it wasn't always something I brought up typically when I was doing my classic history on a school-based patient. I would say, lazy eye or eye turn. I wouldn't necessarily always think until working with this practice so much about talking about corneal health. And I will say the phrase. And of course, sometimes at the population I'm at right now, they do know the term because a lot of the patients have, they're aware of it, that they have the condition themselves. But if they don't, I might, they might not know keratoconus or any problems even with the cornea, but I'll say, is there anybody in the family that needed to wear contact lenses? They couldn't wear glasses. It was hard for them to see correctly, so they needed contact lenses. Or is there anybody in the family that, had to have surgery at all, couldn't see very well despite wearing glasses? Again, red flag might go up that I might need to be ordering some tomography. And then, of course, our steep keratometry readings, obviously, anything above where we would expect, we're going to kind of think this is a little odd. We might want to follow up with some tomography there as well. And I have on here 2 contact lens patients. And so, again, now being at the practice that I'm at and kind of pairing that with the Eye Institute, it's definitely a different patient population with both of the places that I'm at. And now doing contact lenses there, we've kind of been able to decide that we know this is so important. And so we're almost using it with all of our contact lenses, especially kids that are interested early, youth that want to start wearing contact lenses. We say, okay, we're going to go ahead and make sure we run all the scans, the aberrometer, the tomographer, and then we sort of bundle it and say, okay, this is a little bit more of an advanced screening, and we include it in our contact lens package. Okay, so if I'm not talking about a general school exam and I'm specifically having a referral to me for a patient, this might be a referral from another OD that is not comfortable seeing pediatric patients or young patients, or maybe it's a referral because they noted difficult refraction or they noted high astigmatism or high prescription that, again, they just weren't comfortable with. Maybe there is a coexisting condition. We've talked about Down syndrome, Marfan's. What about, Ehlers-Danlos, any of those conditions that, again, we might have to think about, looking at the corneal integrity as well. So having those patients come in, we might be already kind of considering that we might need to run a scan earlier on. Commonly, we'll see patients, though, that just have decreased vision and they are considering, this might be an amblyopic patient. So important to think about that and knowing our objective scope, knowing our objective findings and saying, okay, what meets the criteria? Is this really an amblyopic patient? Have we looked into all of our strabismic factors, our microstrabismic factors, right? Small angle tropes. And if those things really aren't there, but our patient, isn't really seeing well, then we need to consider more ocular health and, of course, some early presentation of keratoconus. So knowing those amblyogenic risk factors that are listed here, right? So with our myopic patients, if it's isometropia, it needs to be greater than 8. With hyperopia, greater than 5. And then for astigmatism, that's where there's the discrepancy, that the 2.5 to 275, right? So we can consider that, thinking about, okay, there's some potential meridional amblyopia there. But if it's less than that, which is a lot of these cases earlier on, then maybe there's something else going on. And then aniso, if we're noticing the difference between both eyes, we want to make sure that the patient doesn't have more than 3 diopters. If they're myopic, that can be a risk factor for amblyopia. For hyperopia would be the 150. And then the astigmatism, of course, is the 150 between both eyes. But if it's a small amount in both and it doesn't meet these criteria, decreased vision, again, consider. So family history of any type of ectasia, keratoconus, we talked about that. That's obviously automatically, we want to have them scanned earlier on. We really need to start working more with our pediatricians to make sure they're aware of this. And doing this presentation, the work that's been done in the research, it's really, I think, become more prevalent that we need to be talking with our pediatric, providers to making sure they're aware that this is an important thing that they don't necessarily see on their screenings that they're giving. So, your pediatrician is classically giving that RetinaMax screening, that machine that basically gives a prescription. It gives, an estimate of a prescription. It gives an estimate of some keratometry readings, and anything that's out of the norm is when they will send them to us, which is great. It gets the patient in our chair. Sometimes it's, over, the accommodation is not controlled. And so we're definitely getting skewed visits, but getting them in the chair is great. But we need more, right? So we need to make sure they're aware of this testing and how critical it is. Okay. So now we're moving on to the how, right? So this is a great point, right? So how young can we start this testing, and when should we do it if we're thinking of performing this test? You know, the referral-based patients, I had said, we already kind of know we're going to maybe be doing that, especially with the family history. But if we start to see signs earlier on in the test, you know, when are we going to be wanting to run our diagnostics? So slightly different than the adult population, we typically will have all of our diagnostics before we go into the room, right? We want to make sure that all the scans have been done, the patient's been worked up for us, they're ready to see us so that we can go ahead and we can assess and we can treat and we can have our plan and we can be efficient and move on to the next room, right? But with kids, again, it's a little different. And we need to make sure, especially with our younger kids, that they're comfortable. And so running them through all that stuff, seeing a technician for a long time before the doctor's able to come into the room doesn't bode well for a patient because of their attention, because of just their comfort, right? And going right into a room with a bunch of machines is not exactly the most comforting thing as well either. So we want to make sure we build that trust with them. And so I often will go in much sooner. I will participate with some young ones in trying to assess visual acuity, alignment measurements, and of course retinoscopy, and making sure they feel comfortable. And maybe we'll consider diagnostics more at a midpoint in the examination than even at the end, because obviously at the end, they're more fatigued now and they've already given us all their best attention. Sometimes I'll tell my students that I want to do the most important things sometimes earlier on when I have their best attention. And then we can kind of get the extras that we're kind of like, okay, those, we got that, that was a bonus, right? So slit lamp practice, I put this in there too, because I might often say, okay, I think I need to be running a tomography on this patient, but I'm going to get them in the slit lamp almost as a trial, as a practice to see how it is to put their head in a device to hold their head up to the top, and how we can do that because they're going to be doing that in the other room.
Dr. Allen, this is Dr. Morgenstern. Hi,
Yes.
we have 1 minute, then we have to go to Q&A. Thank you.
Perfect. Sorry. So what age can we begin? I say old enough to fixate, old enough to attempt scanning. So distract and engage. I sing, I kind of tell them things to kind of keep their attention in the machine. We might have different people holding the back of their head. I might be telling them things like, there's a light that's red. Make sure you're taking a look at it. Focus. It might turn orange. It might turn yellow. We all know it doesn't change colors just like any other light. But again, that can keep them engaged and hold them in there. If we don't get great scans at the beginning, guys, it doesn't mean it was a failure. Scanning can be a training, just like our visual fields can be a training. So we want to make sure that we establish that because they can improve with time and it's critical to get that data. Let me advance here really quick. I do have a quick little video here, just briefly, that we can kind of look. We're looking again at a pen light reflex, looking straight at a pediatric patient. You can see she's comfortable in her mom's arms. Her mom is using her hand as for occlusion. The pen light is actually showing that reflex right there. We already have advanced its stage right here. You can see it's not a classic pinpoint. We have like the bull's eye appearance there, which is of course concerning. Moving on here, billing, we do not have a diagnosis code for keratoconus risk or any corneal ectasia, which is of concern. We do have that, of course, for glaucoma, and so it is much easier for us to throw this in and be able to get the scans. But like I said, we can potentially bundle it even with contact lens fitting, or if we have a pediatric patient with these familial risks, we're seeing some clinical signs or even no clinical signs, but familial risk, we can run the tomography with a screening fee that we've attached, depending on, say, you know, I'm talking to the parents and saying it's important to run this. The test costs this. It is not covered by your insurance, and majority of parents will comply. And just as a note, you know, there is no genetic testing available right now. It was, and hopefully it's again on the horizon. And if that becomes available again, it's just, you know, knowledge is power. Knowing more data can help us align when we want to see the patient back, what's most critical, and how soon that will be. You know, we've talked about the itching, the rubbing. Make sure that's a takeaway, that you guys we're making sure you're addressing that. If there's any family history, make sure you're scanning sooner and earlier. how critical tomography is in early diagnosis. And if you do not have that, this is the who around you can you find that you can refer to. Get to know those local offices and open communication with those MDs and ODs so that you don't, are able to really feel comfortable. You're not going to lose your patient. They'll be referred back to you, as long as you have that open communication with that MD or OD office that, you both can participate in the care, because there is, so much to be seen.